and Mia, and let them introduce yourself if that's okay.
Thanks very much, Emma. So my name is Paul Anders. I'm the trial manager for the IPS AD trial, which has been running in 7 parts of the country since 2018, including in Brighton and Hove, where Mia is joining us from. Mia, are you here and would you like to say hello?
Yeah, thanks, Paul. Hi, everyone. I'm Mia. I'm the IPS Employment Specialist for CGL in Brighton and Hove.
Okay, thanks very much, Mia. And what I'd like to do today is really just sort of take a bit of a whistle-stop tour, summarising IPS AD, what its origins are, where we've got to, what we would hope the future might look like, and then very happy to have any sort of discussion or questions. I think perhaps as we go along, but certainly afterwards. I'm conscious that we have some other people very much involved in the IPS world with us today. I can see Warren's just joined, and we have Karen from DWP as well. So there's a bit of an IPS contingent here, but I think primarily me and Mia from IPS in alcohol and drug treatment services. Okay, if we can move on to the next slide, please. Thank you. So to break down what we'd like to talk about today, so the background to the trial, a little bit about individual placement and support. It's a sometimes, I think, quite complex intervention that is quite challenging to pull together and to make work effectively. But I think conceptually it's also quite simple. We'll talk a little bit about trial outcomes. So we're not in a position to say anything about the outcomes we've achieved, but we can talk through the outcomes that we will be monitoring in the analysis. Talk about the analysis publication plans, and then as a bit of a treat, although perhaps it's a treat for me, maybe less so for others. What we can do is share some service outcome data, and this includes the period that's been very badly affected by COVID. So hopefully that will be of interest to people. Okay, if we can move on to the next slide, please. Okay, so improving or increasing the flow of people from community drug and alcohol treatment into work has been a very long-standing policy goal of successive governments, but very little progress has been made, really. Regardless of the state of the economy, regardless of the resources put into drug and alcohol treatment or into labour market programme provision, the numbers have flatlined, and we often talk about the disability employment gap, which is quite significant in the UK. It's the gap is wider than it is in at least some fairly similar countries. We can do the same sort of exercise looking at the employment gap for people in treatment, and so we can see there that the employment gap is absolutely massive, and that there's very little movement between entering a service and a 6-month review, and actually it's that tends to stay sort of quite flat well beyond the 6-month review point. So we know that there's a gap there. That the interest in fixing it, I think, it has many facets. So there's good evidence that employment is associated with improved treatment outcomes, less frequent, less severe relapse. We also know that good work, and I think good work is important here, is good for health and well-being, and the bad work is actually quite detrimental to health and well-being. Dame Carol Black was asked to look at this back in 2015. She was very keen to make work part of the journey, not the destination, not the end point. And she identified IPS as a promising intervention that should be subject to a randomized control trial. Okay, can we move on to the next slide, please? Thanks. So a little bit about the background of individual placement and support. So it was developed in the United States from the 80s onwards. We're very lucky to be working with some of the team that were the originators of the intervention. So a fantastic opportunity to work with people who have really sort of shaped this intervention and driven it to a point where it's a sort of global global rollout. So the intervention was initially developed in the context of serious severe enduring mental ill health. It's now being trialled with other cohorts. So in the UK, it's being trialled in primary care. It's being trialled with musculoskeletal conditions, and internationally, it's also being trialled with military veterans, for example. At its foundation, it is supported employment, but in a mainstream setting. So traditionally, when people talk about supported employment, it might often mean things like the old Remploy factories, which I think almost all of which were shut down over the last 10 years or so. What this does is that it's a similar sort of concept, but the idea is that the support follows the individual into a mainstream employment setting. There is a wealth of evidence from multiple RCTs, primarily in the US, but also from the UK, elsewhere in Europe, Australia and New Zealand. And there are 3 RCTs ongoing at the moment, one of which is IPS AD, the other 2 being run by DWP. Generally, it has found to be 2 to 3 times more effective than conventional employment support. And that's a fairly consistent ratio across the board. It is often quite unfairly categorized as a sort of high-cost boutique intervention, which is not really suitable for scaling up. I think what we're finding is that isn't necessarily the case. I think if we look at the costs that our 7 sites are delivering at, it's very much in the realm of the unit cost of things like the work program, the work and health program. So I don't think there's any basis as far as that's concerned why IPS couldn't be scaled up much more widely. And certainly in the world of mental health, it is being scaled up much more widely. NHS England has been backing a massive expansion of IPS, which now covers all of England, which will make England the most IPS intensive country in the world. So there'll be more, by the time the rollout is complete and the services are up to capacity, there'll be more people accessing IPS in England than in any other country. It's a manualized intervention, so there's a fidelity review process, and the purpose of fidelity reviews is to improve delivery, improve outcomes by having the services assessed independently the 25-item fidelity scale, which sits within a within an IPS manual that goes on for about 300 pages. So you can buy the book in effect, and delivering IPS is set out in that very manualized form. Out of the 7 sites that we have, 5 attained good fidelity, which is over 100 out of 125 points, which I think is quite remarkable in the short space of time that we've been running, and is very much to the credit of Mia, her colleagues in Brighton, and her colleagues at the other 6 sites that have been working with us. So very quickly, just run through the 8 principles of IPS. Because we were running on a trial basis, we couldn't fully meet all of these, but we certainly fully met most and partially met the rest. So it's open to anybody at any stage of treatment. There are no eligibility criteria. The employment support is deeply integrated with treatment. So Mia, her counterparts elsewhere, are working as part of treatment services within clinical teams, participating fully in every aspect of the service. Competitive employment is the goal, so it's about paid competitive employment. It's not about work experience or ring-fenced jobs or anything like that. Rapid job search, so it's a work-first intervention, and the idea is that in normal times, and I think COVID obviously makes many aspects of this more difficult. In normal times, we would hope that there would be the first contact with an employer within 4 weeks of starting. It's highly personalised, so all of the IPS specialists are working with small caseloads, which should really be no higher than 25 at a time. So highly personalised, highly and preference-led as well. So employers are approached the needs of individuals in mind. So very often with conventional labour market programmes, that the employer engagement focus will be on bulk in effect. So it'll be about, for example, going to talk to Sainsbury's and trying to generate a load of openings there for large numbers of people. IPS is much more preference based. So if somebody wants to become a taxidermist or a furniture upholsterer, for example, then the focus will be on helping people to get into that particular type of work, or at least helping people to take a step towards it, because not all of people's preferences will be immediately attainable. In-work support is provided, so this is, I think, again, one of the key factors that differentiates IPS from conventional employment support. So the in-work support is provided, and that can be anywhere from check-ins through to the IPS specialist going into the workplace alongside their client, and working alongside them, although with the expectation that there'd be a sort of a tapering off of support in that respect. And welfare benefits advice is deeply integrated. So whenever people are looking at moving from being out of work to in work, particularly where things like health and disability benefits, related benefits are involved, people really need to be able to make an informed decision about what type of work, what type of hours, salary, and so on will be right and will be attainable for them. If we can move on to the next slide, please. So I just want to talk here about the outcomes that we will be monitoring in the trial. We're taking a very wide range of outcomes because we are trying to look at a range of vocational outcomes, but we're also trying to put together a fairly comprehensive cost-benefit analysis, which will hopefully, if the outcomes go in the right direction, which will hopefully strengthen the case for wider availability of IPS in future. So the primary outcome, and this is a standard one across pretty much all IPS trials, is at least 1 day of paid employment in the 18 months following starting the intervention. Now that obviously doesn't really tell us very much that of use from either a sort of a public purse perspective or in terms of benefit to the individual. So we'll be looking at a number of secondary outcomes. So total time worked, time to first employment, number of jobs held, job sustainment. That we'll be using some survey-based measures, so job search self-efficacy. We'll also be using EQ5D5L, health status, to monitor changes in well-being. We will be looking at drug and alcohol treatment outcomes, and we'll be looking at social and health outcomes, including changes to benefits claimed and tax credits claimed, tax paid, use of hospital services, deaths, criminal convictions and prison sentences. So we've got a pretty comprehensive suite of outcomes there that should hopefully allow us to make a persuasive case for future investment. Can we move on to the next slide, please? So analysis and publication. We can start the analysis at the 1st of April 2021, which will be 18 months from the last enrolment. We are currently drafting a statistical analysis plan and health economics analysis plan that we will be publishing online before the end of March. We've had a really substantial sort of external qualitative process evaluation conducted by RAND Europe and the Centre for Mental Health. And the aim is that we'll be publishing that evaluation and also the impact analysis later this year. I think that there's an element of fingers being crossed at this point due to data lag and COVID-19. And where we would like to get to at the end of this is hopefully the evidence would support a further rollout of IPS. Very happy to say that that we've agreed with our friends at DWP that IPS can continue to be delivered at the 6 remaining IPS AD sites. So that's Brighton, the others are Blackpool, Birmingham, Derbyshire, Sheffield and Staffordshire. So we'll be continuing IPS delivery to at least the end of March 2022. The trial has finished, so for the last year or so, that's been running on a service basis. And on the final couple of slides, if we can move on, please. We've got some data to share here from the IPS services. So we're looking here at job starts between the 17th of November and Christmas Eve. A fairly successful period where we added 20, well, our partners added 28 job starts over that 6-week period, which I think it is great considering how small the teams are, the limited caseloads they're working with, and also the huge difficulty of working against the context of COVID and lockdowns. And we can see here that Brighton are actually in second place in job start rates. So we have our fellow seaside town Blackpool on 43% into work, and our seaside city Brighton and Hove in a very creditable second place with 33%. And we can also see that all of the sites are over 20%. Some are very close to 30%, which will be regarded as being a sort of a really solid level of attainment, I think, for an IPS service in good times, in normal times. And I think, as we all know, these are anything but normal. If we can move on to, I think, what is one of the final slides. I just thought people might be interested here in seeing the effect of lockdown and of COVID. And what we have is the orange line is enrolment, so service take up, and the grey line is first job starts. So we can see at the approximate start of lockdown 1, we flatlined for a number of months. And I think that was entirely understandable in the circumstances. And what's amazed me is the way that from sort of June, July onwards, the way that things have really picked up, and our teams, the IPS teams, have had to totally reconfigure the way that they work, and they've been doing that alongside their partners in treatment services, who have also, as many in the room will know, who've also had to entirely reconfigure the way that they work. So I think the way those lines start to move upwards from sort of mid-year 2020 is a credit, I think, to everybody involved. If we can move on, I think we might have. So we've got some further reading here, but we've also got a leaflet that was produced by the by the Brighton and Hove IPS team. And Mia, would you like perhaps to come in and just say a few words about this, please?
Yeah. Thanks, Paul. I just wanted to speak a little bit on the area of like for us to IPS. In our experience of working with people who are homeless or insecurely housed, it can be things that might seem small and might end up complex for that person or their employment opportunities. Things like if that person managed to get to a day centre, if they had access to a phone to communicate with us, access to a shower, all these things might be looked over for the average person in employment support. But for someone who is homeless, they can be really key things that can affect their job or their ability to find work. One of the great things about IPS that Paul mentioned, one of the key principles of IPS, is that our service is open to working with anyone, regardless of their housing situation, of their recovery status, or their point in treatment. And I think this is the key message that we try and send to the staff in our service, just to have that conversation around employment with their service users and kind of get the ball rolling. It may not be something that they've considered or that the care coordinator has thought about for that person, but just that initial conversation of, we have an employment support service here. They're really keen to work with anyone who is motivated to find work. It can really open up a lot of doors for people. For us, implementing employment support in a substance use service, we initially spent a lot of time working on the culture of work for people in recovery. And I think this applies to homelessness as well, in that there's this sort of preconceived notion that work might worsen the person's situation, or that they aren't ready, or that they have to be clean and sober or fully housed or secure to find work. Of course, this might be the case for some people, but I think we have definitely proven that finding employment, even if it's just the process of looking for work, or if it's a part-time role, not necessarily full-time work, it can really help to boost all the other parts of someone's life. It can increase their motivation, it can give them that structure and that daily routine. It can help them to socialise, and it can be really beneficial for their self-esteem. The way we managed to sort of turn around this culture on this idea was really just winning over the staff. We share regular bulletins to the wider service of our progress. So that statistic Paul mentioned, we have that 33% of people in our service in Brighton and Hove maintaining work. So we know that it does work. We share good news stories to individual care coordinators about their service users. And we even started competitions for referrals. So all these things combined really allowed us to evidence that IPS was really worthwhile for the wider service, but more importantly for individual service users themselves. So this leaflet is just kind of the information that we give out when we spread them out throughout the wider service. We ask people to give them to their clients, especially if it's someone coming into treatment for the first time. It's just good to know that service is there for them, and that it is there for whenever they're ready. I'm happy to take any other further questions if anyone has any. Thank you.
Thanks, Mia. I've seen that there have been a few in chat. Jessica, your points here. Hopefully, I think Mia has probably touched on some of those when talking about the types of success that they've seen in Brighton. And also, we have to recognise that ultimately everybody is different. Everybody's capacity and capability is different, and we've learned very clearly through the trial that things like confidence and motivation and complexity changes over time. So it is straightforward, but as we've seen in other settings, we really hope that we will show in the analysis that IPS has made a difference to at least some people. So we think that there is real hope there. And Sandy, and hello Sandy, by the way, long time see, about complexity and the evaluation. So I think that will be touched on in the sort of the qualitative external evaluation. Certainly in the analysis that we do try to capture a range of baseline characteristics, and we will also get further information on some aspects of that, primarily sort of vocational, tax and benefits and so on, and also treatment and use of health services that we can include in the analysis. So I'm not going to claim for a second that we will capture that, you know, the full breadth of complexity that you'll all be so accustomed to working with, but we should at least be able to include some of that in the analysis.
Thanks, Paul and Mia. That's really helpful. Are there any other questions, or does anyone else want to come in? Jess, did you want to come back, or has that answered your, or picked up on your? No.
I mean, just to wrap up, and I realise that we are pretty much at the end of our allotted time. If anybody would like to get in touch with me after the meeting, I would be very happy to pick anything up by email or phone, and my email address is on the slides. And Mia, I'm sure you from a sort of local Brighton and Hove perspective will be happy too.
Yeah, absolutely.
That's brilliant. Thank you ever so much. That's really helpful. And I think that's, especially as we start to move through the pandemic and start to be able to see the wood for the trees, I'm sure more and more people will be really keen to tap into some of your expertise around this.